Having troubles falling asleep? Well, look no further. This video today is going to talk to you about cardiogenic shock. Cardiogenic shock is of the cardiac variety, which means it has to do with the heart. So this is what our heart really looks like. Its main purpose is to oxygenate blood and pump it around to the rest of the body so we can perfuse the rest of our tissues. The heart first starts by receiving deoxygenated blood from the body through the superior and the inferior vena cava. It goes through the right atrium, through the valves down to the left atrium, out to the lungs where it becomes oxygenated, and returns through the heart through the pulmonary veins. This then goes to the left side of the heart, through the left atrial, down to the left ventricle, then gets pushed out to the rest of the body, through the aorta, from the head down to our feet. Now this is a lot of ground for our heart to cover. That's why our heart is very strong, especially that left ventricle right there. It has got to be big enough to supply the pressure to push the blood all through our body. Now that we know what the heart is, what's cardiogenic shock?
Hi, I'm Dr. Morrison, and I'm here today at the Holland College campus, and we're interviewing students and asking them what they think shock is.
I think shock is when you just absolutely go brain dead for a split second and you can't function at all.
So what do you think shock is?
What kind of shock?
Cardiogenic shock.
Something to do with shock in the heart.
Now that we've heard some pretty good guesses, our nurse here, Miss Leckman, is going to tell us what cardiogenic shock is.
Cardiogenic shock occurs when the heart cannot pump enough blood to meet the perfusion needs of the body. The most common cause is acute myocardial infarction, especially if it's on the left side of the heart, because the left side of your heart has the most resistance against it, because the heart has to pump to the entire body rather than just to your lungs. Another cause is acute worsening of congestive heart failure. This can result from ventricular septal defects or cardiac myopathies. Causes of cardiac myopathies would include chronic lung disease, valvular stenosis, and hypertension, because they add increased pressure on the heart, so the heart has to work super hard, and eventually the heart just fails because of all this increased pressure.
Here we have a hypertrophic heart. Notice how it takes up more than half of the mediastinum space? You can see how jacked the myocardium is. This is due to the body compensating against high pressures that the heart has to pump against. The problem? Decreased ventricular filling because there isn't enough room for the blood, which leads to decreased cardiac output. The next heart we have is a restrictive heart. The walls are rigid and don't contract properly when pumping blood. We also have a dilated heart. In this heart, the muscle becomes weak and floppy, which leads to uncoordinated pumping.
Other less common causes would be dysrhythmias. They can either be naturally or drug-induced, and these kind of dysrhythmias would be bradyrhythms or tachyrhythms that lead to decreased perfusion. Another cause is trauma. So myocardial contusions occur in traumatic events, and they basically cause cell damage to your heart, resulting in a decreased cardiac output.
People at risk for cardiogenic shock are those with a family history of heart disease, people with poor lifestyle choices, people with diabetes, those with high blood pressure or high cholesterol, the elderly, those that are African or Asian ethnicity, and those with genetic disorders.
Okay, that seems to make sense. But if I were to see this, what would it look like? Since we're all not that smart and can't recognize it on the spot, here are some good things to look for. A patient in cardiogenic shock will experience cool, clammy hands due to poor perfusion, JVD due to right-sided failure, pulmonary edema due to left-sided heart failure, which means there'll be fluid in the lungs. This fluid can be pink, so they'll have pink sputum, shortness of breath, due to the pulmonary edema and the sputum, as well as they can experience weak pulses, slow cap refill, altered mental status, or loss of consciousness due to the decreased perfusion to the brain, so the brain's not working as well, and lower urine output due to low perfusion to the kidneys, as well as radiating chest pain. Now for each patient, this chest pain can radiate to their arm, to their jaw, to their back, or their abdomen. It all depends on the patient.
Here we have a patient in compensated cardiogenic shock. This is an earlier stage of shock. Next we have decompensated. This patient is critical and all vital signs are failing. This leads to irreversible shock.
Hello, I'm Dr. D, and we're going to look at some diagnostic tools we can use for diagnosing cardiogenic shock. So in addition with all the signs and symptoms we just looked at, we're going to look at 12 leads. So ECGs, you will see in the ST area, you'll either see depression or elevation, as well as different dysrhythmias you can see, as well as in labs. Labs are very important. When you're taking blood tests, one thing you'll see right away is an increase in myoglobin, as well as an increase in serum lactate from anaerobic metabolism, as well as an elevation in troponin after 3 to 4 hours. This is a cardiac specific marker. As well as you'll see an increase in BNP, which is an enzyme that the ventricular cells will release when they are overstressed. As well as, if you have the time, you can do some cardiac catheterization. And when you do this, you can read levels of CWP, an increase of cerebral venous pressure, and a cardiac index of less than 2.2.
So for treatments for a PCP, there's a few things that we can do. The first thing you want to do is you want to make sure you manage your ABCs. The second thing, we can give oxygen, so you want to make sure the SpO2 stat is above 94%. We can give fluids, but we want to be cautious about that. And then the main thing to do is we want to transport and call for ACP intercept along the way.
So for ACP protocols for cardiogenic shock, as a responsible ACP that I am, I would go use our Island EMS app. So cardiogenic shock, you've done all the PCP things, the BLS, and then you start treating. If they have CHF, chest pain, MI with hypoperfusion, you can start with a 250 cc bolus, and then you can then administer dopamine. If it's bradycardia with hyperperfusion, you can start with atropine. And if it's a patient that's ineffective, you could give them epi, and then continue on to dopamine. If it's SVT or VT, like narrow-complex SVT, then you'd go on to adenosine, and then you can pace, as well as VTAC with wide complex. You can cardiovert, and always transport.
Patients in cardiogenic shock, we're definitely going to be careful with how much fluids we give them. Giving them fluids can actually worsen their condition, so we might want to just hold off on fluids altogether, check lung sounds in between if we have to give them fluids. And we're going to treat them with nitro and ASA if they're in compensating shock, so their blood pressure is above 100. If they're in CHF, I guess, we can treat with nitro, CPAP, and we're also just going to manage their pain all the way to the hospital. If we have the time, we're going to fill out a reperfusion checklist. This will just kind of be one less thing that the nurses have to do when we get there, speed the process up a bit.
Once the patient reaches the hospital, they will continue any pre-hospital interventions that have been done, along with some more advanced ones. They will confirm the diagnosis, and then they can do more advanced treatments such as an intra-aortic balloon pump. They can put in a pacemaker, they can put in a stent, and they can also give more advanced drugs. Patients who are in cardiogenic shock don't have a very good outcome, and usually 80% of these patients will die.